morning from France. It's my pleasure here to be and to share with you some information on Untitled Vasculitis, which is a group of diseases with some specificities. Here are my links of interest. I would like to tell you first the main characteristic of this Untitled Vasculitis. There are vasculitis affecting small-side arteries, capillaries, and venules. The two ANCA subtypes which are useful for the clinician are the anti-myeloperoxidase, which is present in EGPA and in MPA, and antiproteinase 3, which is present in GPA. When lung and kidney involvements are present, that's a consequence of the capillaritis, and it explains the presence of the lung hemorrhage and the occurrence of a glomerulonephritis, which is rapidly progressive and very severe without treatment. In addition, there's a granuloma formation in GPA and EGPA, but not in MPA. The ANCA are shown here in immunofluorescence, cytoplasmic when anti-PR3 are present, and perinuclear when anti-MPO are present in ELISA. These ANCA have defined a part of the small vessel vasculitis category in the Chapelier nomenclature, and you see here this group of 3 vasculitis, MPA, GPA, and EGPA. But it is other small vessel vasculitis due to other mechanisms like immune complexes. The pathogenesis has been described now many years ago, and the PR3 is present in the polynuclear cells, and with the help of a stimulus, we do not know the primary antigen, but with the intervention of TNF-alpha and some other cytokines, there is an expression of the PR3 at the cell surface. This, of course, has a consequence to produce antibodies to the PR3, and this antibody, after that, will, with the help of adhesion molecules, create a very strong adhesion of the polynuclear cells to the endothelium, and after some activation with oxygen active and Fc gamma receptor, there is a destruction of the endothelial cells, and the pathogenesis is very present to induce vasculitis. The antibody is pathogenic. When you inject myeloperoxidase to knockout mice, the mice produce anti-MPO, ANCA. And when you inject the anti-MPO ANCA to another mice, the RAC2 knockout mice, these mice produce IgG, anti-MPO, and after that, the mice develop post-immune glomerulonephritis. There is some other important points to know. And on the polynuclear cells, there is some nets, neutrophil extracellular traps, and these nets contribute also to the pathogenic process with an increase of inflammation, glomerulofibrosis, and they favor thrombosis and atheromatosis. Here you see that they contribute to the formation of the GPA granuloma, and the nets stimulate also the ANCA production and create a vicious circle. And at the end, the net's deposition induce inflammation, the thrombosis, and the fibrosis of the glomerulus. The spectrum of ANCA-associated vasculitis can range from some localized disease, which is the case in some patients with GPA, to a more systemic and generalized disease, which can lead to the occurrence of severe GPA. The ANCA significance is well known now. In systemic GPA, more than 80% of the patients present the ANCA. It is only half of the patients with localized GPA. For MPA, it's a bit different. I have mentioned that only 50% of the patients present ANCA anti-myeloperoxidase. It is, of course, 90% when the patients present with a glomerulonephritis, and all the kidney patients have ANCA. But there is some other forms of MPA affecting joints, skin, for instance, without lung or kidney involvement. And in these patients, the presence of anti-MPO antibodies is not so high. In eGPA, the anti-MPO antibodies are observed in only 30% of the patients. And it is a consequence of the heterogeneous pathogenesis of eGPA. This disease is sometimes a consequence or associated with ANCA, but in other patients, the vasculitis can be also the consequence of eosinophils and some cytokines like interleukin-5. And as a reminder, I would like to say that in polyarthritis nodosa, you never observe ANCA. What about the treatment? Some points are important to know when you see the treatment of all the vasculitis, not only the group of ANCA-associated vasculitis. The cyclophosphamide has been introduced at the end of the 70s. The hepatitis B virus and hepatitis C virus have been described as causes of some vasculitis, which are not linked to ANCA, and specific treatment should be done and should be prescribed. The ANCA have been discovered in 1985, the anti-MPO in 1988, and they define the group that we know now, and it is a major advance with the Chapelier nomenclature. When you look at this slide, which has been published in 1979, you see it is here polyarthritis nodosa, but probably also MPA because it was not so well described. You see that some patients did not receive any treatment and die. Steroids have some effect, but not very good effect, and the majority die also. And the benefit, in fact, came from the prescription of immunosuppressants. How to treat now? We have to adapt the treatment to the vasculitis type. We do not give exactly the same treatment to a polyarthritis nodosa related to HBV or to cryo related to HCV and to ANCA-associated vasculitis. And the potential in terms to consider to adapt treatment are, in addition to the vasculitis type, the severity scores, and we'll come back on that point later, some markers predicting relapse, and it is important to know for the long term, and some genetic markers which could have in the future some interest. Now we have a new era of treatment with the prescription instead of immunosuppressants, some new drugs targeting some specific mechanisms. These monoclonal antibodies like rituximab, but also mepolizumab and other drugs, could revolutionize treatment of vasculitis, but they have to demonstrate that they provide a long-term significant benefit. These new drugs are more expensive, and to prescribe them, we have to demonstrate that they are not only effective, or safer, but also efficient in terms of direct and indirect costs. To summarize, the treatment of vasculitis is a first step for induction of remission. It is a short treatment, 3 to 6 months. We personally prefer to treat patients with pulse cyclophosphamide, but you can prescribe oral cyclophosphamide. This treatment is, of course, easier to give because patients have not to come to the hospital, but you deliver more cyclophosphamide when you prescribe tablets, and the toxicities could be higher in the future and also in the short term. After induction of remission, the maintenance treatment can start, and it is 18 to 24 months. Usually we give azathioprine or methotrexate. The results of this conventional treatment is excellent. When you look at these slides coming from the UVAS group, the survival ranges from 78% to 92%, 78 for very, very severe patients and 92% for the others. In the French vasculitis study group, when the group is FFS 0, which means no symptoms of severity, the survival is also very good, 92%. And when there is markers of severity, FFS higher than 1, the survival rate is also excellent with 90% at 7 years. And in the RAVE study, in the arm receiving rituximab, the survival at 18 months was 99%. In fact, we know now that we can treat effectively patients with vasculitis, whatever the treatment is given. And rituximab is as effective as conventional treatments. What about plasma exchanges? Plasma exchanges have been proposed in some severe patients. We made a prospective trial many years ago. It was published in 1992 and demonstrated that when you compare steroids and steroid plus plasma exchanges, you do not improve survival. It is the same when you combine steroid and cyclophosphamide and compare to steroid, cyclophosphamide, and plasma exchanges. More recently, the plasma exchanges were randomized. It's a very large study with more than 700 patients, and it was a double randomization, the first one for plasma exchanges and the second one for the steroid dose. And the result of the study is summarized here. At 5 years, you can see there is no difference in the group receiving plasma exchanges and the group receiving no plasma exchange. And there is also no difference in patients receiving higher dose and those with low dose. It means, in fact, that for the general population of patients with ANCA-associated vasculitis, plasma exchanges does not provide any benefit. But there is some indications to give plasma exchanges. First, it can be effective after failure of all other treatments, steroids, immunosuppressant, pulses. They also are very effective in case of severe alveolar hemorrhage. And plasma exchanges could be effective also in some acute severe clinical manifestations like mononeuropathy multiplex. There is a niche, but there is some interest to keep the plasma exchanges in your armamentarium of treatments. What about the prevention of relapses? The conventional treatment was azathioprine or methotrexate. In this first study, comparing a long-term cyclophosphamide for maintenance after induction and another group with azathioprine for maintenance, there is no difference between both groups. And now nobody prescribes a long-term treatment with cyclophosphamide to keep patients in remission. We compared also azathioprine to methotrexate after an induction of remission with pulse cyclophosphamide. And you can see that both drugs give the same results. But what is obvious is that at 3 years, the relapse rate is high and that these drugs are not very effective to keep patients in remission. More recently, mycophenolate mofetil has been tried, and this drug is not superior to azathioprine, it is inferior to azathioprine. And we do not recommend mycophenolate mofetil as a systematic maintenance treatment in patients with ANCA-associated vasculitis. To summarize, you can see that MMF and azathioprine are not excellent as methotrexate to keep patients in remission. And when you look also at the main recent trial, but I will detail this trial later on, the group taking azathioprine had also a relapse rate of 28% at 28 months. Now, I would like to comment a RAVE study. It is a very good study. And after 1 to 3 pulses methylprednisolone, patients were treated in one arm with conventional treatment, oral cyclophosphamide or steroids, followed by azathioprine, and in the other group, rituximab, 4 infusions and nothing after except a placebo. And the first analysis has been made at 6 months. And at 6 months, the primary endpoint, which was a BVAS at 0 and stopping corticosteroid, was reached by more than half of the patients. And it is a non-inferiority of rituximab to cyclophosphamide. The second study, which was published, was the follow-up of the same series of patients at 18 months. And you can see that the survival curve without relapse is the same if the patient have received azathioprine for maintenance or a placebo after induction with rituximab. And it demonstrates clearly that azathioprine is not useful when you induce the treatment with rituximab, because with placebo, the results are the same. But I think that it doesn't show that it is interesting and positive for the patients to choose another treatment for maintenance. Because here at 18 months, 40% of the patients have relapsed, which is not very, very satisfactory for the patient and for the clinicians. And for this reason, we made this trial, rituximab versus azathioprine for maintenance in ANCA-associated vasculitis. And this maintenance treatment, the details is shown here. Azathioprine for reference treatment, 22 months. And for pulse rituximab, the dose was only 500 milligrams every 6 months. And we stopped treatment at 18 months, and the evaluation was made at 28 months. The results are clear. The major relapse, 28%, are in the group with azathioprine, and in the group with rituximab, it is only 5%. The survival is also very good at 5 years. And when you look at the relapse rate, you can observe that there is relapses in both groups, but of course, higher relapses in the group of patients taking azathioprine. Rituximab, it is better. But when you stop rituximab after 18 months, you can observe that there is some relapses after, and it is not neglectable. And of course, we have to evaluate also if it will be useful to treat longer patients with rituximab. The conclusion is clear. Rituximab is more effective than azathioprine and also methotrexate and so on to reduce relapse rate in ANCA-associated vasculitis. To prevent relapses, we could also adapt the treatment to biological markers. As a clinician, you probably prescribe regularly CD20 ANCA testing during follow-up of these patients. But what do you make with the results? And we try to understand if it is useful to make such survey. First of all, the RAVE study has also shown that there is less relapse when patients are anti-MPO than when patients are anti-PR3, and it is independent of the combination of treatment which was prescribed. Anti-MPO patients relapse less than anti-PR3 patients. And it is fantastic to know that because it could help for the future treatments. With the MENRITSON 2 study, we try to determine whether treatment adapted to ANCA status and CD19 is as effective as a fixed administration schedule. It was in fact an on-demand infusions of rituximab versus a fixed dose rituximab. We have treated 162 patients in this trial. The fixed dose was MENRITSON 1 trial, and the second one is on demand. When patients have increase in ANCA titer or the reoccurrence of CD19, they were infused. If we had a stable level of markers or no marker, they were not infused. And the results are summarized here. First, with a fixed dose, it was 5 infusions. On demand, only 3 doses. It was possible to control the disease with these 3 doses. The relapses are not different in both groups, all relapses and also major relapses. The differences are not significant. The survival was the same and excellent in both groups. What about the interest of CD19 and ANCA titer? Unfortunately, these titers do not predict the occurrence of relapses. It was the same in both groups. And it is quite deceiving because what is important is not to adapt the treatment to markers, but you have to know that what is important is a presence, for instance, of the ANCA. When you look at the patients who are PR3 ANCA in green, they have a high relapse rate. When they have anti-MPO antibodies, or when they have negative, the level of antibodies has disappeared during treatment, there is an intermediate response in terms of relapses. And of course, for the patients who have no ANCA, the relapse rate is very low. And it confirms what has been shown by our American colleagues, that the marker which is important to predict relapse is not the CD19, it is not the ANCA titer, it is the presence or the absence of ANCA and the disappearance or not of ANCA. And after the results of these 2 trials, we understood that some patients should probably be treated more than 18 months. And we have re-randomized the patients to receive additional 4 infusions of rituximab versus placebo. And we made a new reevaluation at 28 months. And the response is clear. It has been published last year in Annals of Internal Medicine. And you can see that the placebo group relapse and the group receiving rituximab does not relapse. And of course, it could be an incentive to keep patients on treatment with rituximab or life, or for a very, very long time. But to treat patients or life can induce also some side effects. And I will come back on that point. On anti-PR3 positivity at day 0 and then 12 predict relapse. CD19 detection does not predict relapse. ANCA titer cannot be used to adapt treatment. And longer you treat, better you reduce the relapse rate. It has not been published, but the Ritazarem trial is now finished. And in this trial, the patients received 1 gram every 6 months of rituximab. The population were patients who had already relapsed. They were more severe than the patients included in the main recent trial. The results confirm that rituximab is superior to azathioprine. And what we don't know is the side effects. The abstract said that there is no difference with such dose of treatment, but of course, we have to know the detail and we'll see the publication. One thing which could be of interest is to adapt the treatment to markers of disease severity. And the 5-factor score has a major interest. As it is summarized here, the age up to 65 years old, a renal insufficiency with creatininemia over 140 micromoles, a cardiomyopathy, a GI involvement, and the absence of ENT manifestations. It is clear that patients with GPA, which present with ENT, have more relapse, but a better outcome than the patients without ENT, which present more frequently lung hemorrhage or kidney involvement. And we use this FFS for stratification of treatments. We use it, in fact, for MPA and eGPA, not for GPA. In patients with GPA, you should treat the patient with a combination of cyclophosphamide and corticosteroids or rituximab and corticosteroids. But when you have a patient with MPA or a minor form of eGPA, you can start with steroids only, and you do not need to have more treatment. And I will also show you that very soon. One also major point is how long to treat with corticosteroids. In the United States, they try to stop steroid at 6 months. In Europe and in many other countries, we keep patients on steroids low dose for 1 year or sometimes more than 1 year. And patients who have eGPA, unfortunately, have to keep some steroids to control the asthma. A retrospective study has shown that the number of relapsed was lower when patients received corticosteroids low dose in the long term, but it is a retrospective study, and some prospective studies are ongoing, and we will know what to do, I hope very soon. As I said previously, we have also to make some medico-economic study, because these new drugs are expensive. And of course, for the social security system, and in some countries, it's very important to give money with a good result and a good quality. What is quality? It is a quality adjusted lab years. When you have a treatment, so quality, for instance, in this one, when you introduce a new treatment, you can have a negative quality loss. And the new treatment, of course, we expect a quality gain. A quality of, it is the cost of the treatment to obtain a 1 year survival in good physical condition. And the medical economic analysis of main reason was 57,000 euros. Of course, it's a lot of money, but it was before the biosimilars. And when you compare to the azathioprine group, you see, in fact, that the ICER, which is the incremental cost effectiveness ratio, was only 224 euros to prevent one relapse. And in fact, the treatment is cost effective because you have so many relapses when you do not treat patients with rituximab that you spend, in fact, a lot of money because patients with relapse go to the hospital and so on, and sometimes die. I would like now to give a few information on mepolizumab because the biotherapies can also be used for treatment of EGPA. EGPA is treated with corticosteroids and in severe forms with immunosuppressants. Patients relapse, patients keep the asthma for years, and during the survival and the survey of the patients, most take inhaled corticosteroids and usually 8 milligrams of prednisone as a mean oral dose. Mepolizumab has been evaluated as an add-on therapy to reduce corticosteroids and prevent the occurrence of relapse, and the study has been published 4 years ago. You can see when you look at remission, the superiority of mepolizumab, and when you look at the number of relapse, the relapses are lower in patients taking mepolizumab. And another very, very important result is that it is possible to reduce the steroid dose in most patients. And the conclusion of this study is that because corticosteroids have some deleterious effects, a steroid-sparing policy can improve outcomes, and the biotherapy helps reduce the corticosteroids. There is some trial of abatacept. It is a salvage therapy sometimes. It gives some quite good results, but it has not been really been yet evaluated as a larger treatment for patients with AAV. And I would like to comment on C5 receptor inhibitors, avacopan. Avacopan has the objective to reduce the use of corticosteroids. The study has been published recently in the February 2221, and patient received in one group avacopan twice a day or placebo in addition to corticosteroids. The induction was rituximab or cyclophosphamide, oral or IV, and no maintenance treatment was given with rituximab. The results show a slight superiority of avacopan versus the reduction of prednisone dose, but the statistical were not so good. Avacopan was not superior to the progressive tapering of prednisone at 26 weeks, but superior at 52 weeks. We do not know everything about the adverse events of the treatment. And the major flaw is that there is no maintenance treatment with rituximab. And of course, patients relapse more because they do not take any maintenance treatment with an effective drug. I would like to, I'm close to the conclusion now, to show you some slides on the genetic markers. 2 GWAS have been done, one for GPA and MPA, and the other one for eGPA. When you look at the GPA and MPA study, you see that there is not a strict coverage of GPA defined on histological and clinical manifestation, and the same for MPA, and the presence of MPO antibodies and PR3 antibodies. There is some overlap. And we can try to go more in deep, and some genes have been described. These genes lead to the production of the antibodies, and of course to the disease development. And you can see that antiproteinase 3 is associated with HLA-DP, and 2 genes, one which leads to the production of proteinase 3, and the other one, alpha-1 antitrypsin. When you study anti-myeloperoxidase, it is HLA-DQ and not HLA-DP. And in eGPA, the subgroup of patients with anti-MPO is also DQ. And when the patients do not present anti-MPO, there is no HLA, but other variants. And of course, now it's only something that we have. We have the information in general studies, but it is not used for practice. And what I think is that in the near future, it will be possible to have the genes for each patient and maybe to orientate the treatments, not the initial treatment, but the long-term treatment on these markers or other new genetic markers. The impact of the genetic markers could be of some interest, maybe for prognosis, maybe to predict the relapse. One slide on COVID-19. Vasculitis are not associated with COVID-19. Very few patients have developed vasculitis after infection, and our patients with vasculitis did not develop more COVID-19, except, of course, in case of immunosuppression. The concern now is that we treat our vasculitis with a prolonged B-cell immunosuppression, rituximab, and maybe that we know that the patients do not develop antibodies after vaccination, and it can be a risk for the patients also to develop severe disease manifestations of COVID-19 if they are contaminated. And we have to be very careful with them and to explain that they should respect all the means to be protected against the virus, like a mask, for instance. As a conclusion, I would say that treatment of vasculitis has improved dramatically over the last decades. The survival improvement has already been obtained with optimal use of conventional treatment and not the new treatments. The biotherapies came after, but the survival has been obtained with a good management of the conventional treatments. There is fewer relapses now with the biotherapies, and of course it is very useful for our patients taking drug in the long term. We can expect some future progress on markers predicting survival, and relapse, maybe genetic markers, maybe not. And also a few words on the COVID pandemia. And maybe also that we have considered other treatments to try to avoid this depletion of B cells for some patients with vasculitis associated to ANCA. I thank you very much for your attention.
Thank you very much, Professor Gillivan.
Thank
for
you.
This remarkable, comprehensive, and covering most of the aspects old and new. Thank you very much for this wonderful presentation. And I think we have just one question. You can see no questions, actually. So we can move to the next. Okay. We have one question from Dr. Dalia Faiz, University of Ain Shams. What is the proper time for vaccine in patients receiving rituximab against COVID-19? Do you prefer special type?
Very difficult to answer this question. And in fact, there is sometimes some need, an urgent need to treat patients with rituximab, and it's very difficult to wait between vaccination and rituximab injection. I think that ideally it would be 2 weeks approximately as a minimum time, but I don't know if it is really feasible in patients and in case of emergency.
Okay. Dr. Dina Abdul Halim Shaheen from Mansoura University. What about pregnancy and AAV?
Anc vasculitis, it's not the problem. In fact, pregnancy is an event which occurs in patients with vasculitis with no risk. It's not like in systemic lupus. The pregnancy does not influence vasculitis, and vasculitis has no effect on pregnancy.
Thank you. I think we'll have to thank you very much, Professor Gillivan. I think
thank you.
We now thank you very much. We wish to have you. We had you with us. Next year, probably we can get rid of this.
We hope so. We hope so.
Okay. See you. Our next speaker is Professor Luca Cantarini, professor of rheumatology, pediatric rheumatology, and Behçet disease in the University of Siena in Italy. Luca is a guru of autoinflammatory diseases, the founder and chief of the Alliance dealing with these diseases. He turned, thanks to his efforts, he turned Siena, the jewel of a city, into a center. His university was turned into a center of excellence and a target for those seeking information and knowledge and treatment for this group of disease. Today he will talk to us about the monogenic autoinflammatory disease. I think we are getting the best information possible and the best concise and comprehensive at the time on the topic. Would you, the platform is yours, Professor Cantarini.
Yes, sir.
We are all ears.
I share my screen.
Yes, please.
Okay, I can start?
Yes, please, go ahead.
Okay, thank you. Before starting, I would like to thank Professor Ragato for the kind invitation. It is a great pleasure for me to be here. I'm going to speak about monogenic autoinflammatory diseases. I want to remind you the definition
Dr.
of
Luca,
a system.
sorry?
Yes?
You didn't share your screen yet. Please share your screen.
Okay.
Okay.
Excuse me?
Okay, doctor.
Okay, excuse me.
Yes, it's now
Uh,
clear.
You know that systemic autoinflammatory disorders are an expanding group of the diseases of the innate immune system that are characterized by seemingly unprovoked attacks of systemic inflammation, typically with the lack of autoantibodies or autoreactive T cells. Hereditary periodic fever syndromes are a subgroup of autoinflammatory disorders, and the most common diseases are represented by familial Mediterranean fever, tumor necrosis factor receptor associated periodic syndrome, hyper-IgD syndrome, and cryopyrin associated periodic syndromes. Three phenotypes of increasing severity from the mildest CAS to the most severe Denomic-Chinka syndrome. All of these disorders are caused by mutations in genes which encodes proteins known to be involved in the regulation or activation of the inflammatory response, and their final common is represented by the activation of the interleukin-1 beta pathway. We know that childhood is the lifetime involved in most inherited autoinflammatory diseases. However, a moderate number of patients may experience a delayed onset during adulthood. The delayed onset is usually related to the presence of low penetrance mutations that are also responsible for a milder phenotype, oligosymptomatic disease, and atypical inflammatory responses. Patients exhibit recurrent fever attacks with localized inflammation involving the skin, so most patients may show peculiar skin rashes. The serosal membranes, usually in the form of serositis or polyserositis, and the synovial membrane, with most patients complaining from arthralgia or even arthritis. So the patients exhibit periodic recurrences with a marked elevation of acute phase reactants, alternating with fever-free and symptom-free intervals, with a spontaneous normalization of acute phase reactants. However, during adulthood, fever episodes may become less frequent, and patients may experience a chronic or subchronic disease course with a slight but persistent elevation of acute phase reactants. Familial Mediterranean fever is the most common autoinflammatory disorder. Familial Mediterranean fever is an autosomal recessive disease. Patients may show typically short recurrent fever attacks lasting 1 to 3 days. May present polyserositis with thoracic pain and abdominal pain, arthralgia or arthritis, peculiar skin rashes such as erysipelas-like erythema, and myalgia. Patients are typically responsive to colchicine treatment, and about 25% of patients, treated patients or not appropriately treated patients may develop over time a reactive amyloidosis. We know hundreds of mutations in the gene responsible for familial Mediterranean fever, but the majority of mutations are located in the exon 2, in the exon 3, in the exon 5, and exon 10. In regard with joint manifestations, arthritis can be observed in about half of patients. Arthritis is more frequent among children, and usually patients may present with a non-deforming, non-erosive mono or oligoarthritis involving large joints of lower limbs. Polyarthritis is rare. The involvement of small joints is uncommon, and also the involvement of upper limbs is quite uncommon. In most cases, arthritis lasts less than arthritis attacks last than 7 days, but 2–5% of patients may develop a chronic arthritis with irreversible damages. The onset of arthritis in patients with FMF is usually associated with the most severe mutation, the M694V mutation, is usually associated with the more severe disease course and also associated with the development of amyloidosis. I want to remind you that about 7% of patients with familial Mediterranean fever may have an axial spondyloarthritis, and they may fulfill the modified New York criteria for diagnosing ankylosing spondylitis. The diagnosis of FMF is a clinical diagnosis. The Taylor-Shomer criteria are the most widely used in adult patients, and they are divided into major criteria and minor criteria, and includes the most peculiar clinical manifestations, but also long-term complications such as the onset of reactive amyloidosis over time and the good response to colchicine treatment. The clinical manifestations during adulthood are similar to those manifestations of younger patients, but in adults, arthritis and skin rashes occur at lower frequencies. The delayed onset of FMF during adulthood is related to the presence of low penetrance mutations, and the delayed onset is usually occurs in males more than in females, is associated with a milder disease course and sometimes also with an oligosymptomatic disease course. These patients usually are responsive to lower doses of colchicine. I want to remind that oligosymptomatic patients carrying low penetrance variants in the gene responsible for familial Mediterranean fever may be characterized by an incomplete clinical picture. In these cases, patients will never fulfill the clinical diagnostic criteria. And in these subjects, the genetic testing is a crucial point to the diagnosis. TRAPS syndrome is the most common autosomal dominant autoinflammatory disorders. Patients may display typically prolonged recurrent fever attacks lasting more than 1 week, but usually lasting several weeks, associated with peculiar skin and ocular manifestations and serosal inflammation. Patients are not responsive to colchicine treatment, but are responsive to glucocorticoids and Il1 inhibitors. Average age at TRAPS onset is about 3 years, but adult onset has commonly been reported over the past years. The delayed onset is related to the presence of low penetrance variants in the gene responsible for TRAPS, but this kind of variants can be found also in patients with recurrent inflammatory attacks who lack the most peculiar TRAPS manifestations. In these subjects, even the duration of the fever episodes may be shorter, resembling the duration of attacks in patients with familial Mediterranean fever. Finally, this kind of mutations can be found also in healthy controls, causing difficulties in the interpretation of the genetic test. In this regard, we have recently evaluated the clinical manifestations and the response to treatment in a cohort of adult patients presenting with recurrent inflammatory attacks and carrying low penetrance variants in the gene responsible for TRAPS. Moreover, in the current study, we provided also data on their long-term follow-up. Briefly, our study results. We reported that the patients carrying low penetrance mutations in the gene responsible for TRAPS, if compared with patients with high penetrance mutations, usually display a lower family history for recurrent inflammatory attacks and usually display a later disease onset. Patients carrying low penetrance variants in the gene responsible for TRAPS were less frequently associated with the most peculiar TRAPS clinical manifestation. Moreover, a distinctive clinical feature was a higher rate of pericarditis in patients, in subjects carrying low penetrance mutations in the gene responsible for TRAPS. More recently, we have tested for mutations in the gene responsible for TRAPS 131 patients presenting recurrent pericarditis as the only clinical manifestation for mutations in the gene responsible for TRAPS. Interestingly, 5% of these patients with recurrent pericarditis carried low penetrance mutations in the gene responsible for TRAPS. A significant association was observed between the presence of the mutations in the gene responsible for TRAPS and the positive family history for pericarditis or recurrent fever attacks, with the number of recurrences per year from the second year from the index attack of pericarditis, since the genetically positive patients did not show any improvement over time with the number of recurrences after starting colchicine treatment, since the patients with the genetically positive patients with recurrent pericarditis did not show any improvement after starting colchicine treatment. Finally, also the need to start immunosuppressive agents over time for treating pericarditis was significantly associated with the presence of mutations. Other atypical TRAPS presentation. In this case, series of patients, we reported patients with peripheral and axial spondyloarthritis carrying low penetrance and high penetrance mutations in the gene responsible for TRAPS. In addition to spondyloarthritis, patients also showed the recurrent fever attacks and a marked elevation of acute phase reactants. In light of these findings and taking into consideration that also patients with familial Mediterranean fever may have an axial or a spondyloarthritis, in our unit is usually performed a genetic testing in these in patients with spondyloarthritis presenting with recurrent fever attacks and a marked elevation of acute phase reactants, in addition to the lack of response to traditional immunosuppressive agents. More recently, we have evaluated also the clinical features and onset and the genetic characterization of pediatric patients and adult patients affected with TRAPS in a series of 80 cases from the AIDA registries. The primary aim of the study was to describe demographic, clinical, and therapeutic features of TRAPS according to the age at the disease onset. And the secondary aim were represented by the description of the cohort according to the penetrance of the gene variants and specific genotype subgroups, to evaluate how TRAPS classification criteria work across different age and genetic groups, and to explore any association between clinical and laboratory features of the whole cohort of patients at the disease onset and potential prognostic indicators. Briefly, the clinical and demographic characteristics of our cohort of patients. We enrolled 44 pediatric patients and 36 patients with a delayed onset during adulthood. 32 patients carried high penetrance variants in the genes responsible for TRAPS, and 44 patients carried the low penetrance mutations in the gene responsible for TRAPS. In the picture, you can observe the clinical characteristics of our patients at the disease onset according to the age at the onset. And you can observe that among clinical aspects during attacks, pericarditis and myalgia were reported more frequently in the context of patients with a delayed onset during adulthood, while abdominal pain was more present in children. Indeed, 84% of children had abdominal pain, and only 25% of adults. This further picture displays the clinical characteristics of our patients at disease onset according to the penetrance of the mutation. As you can see, subjects carrying high penetrance mutations had a consistent family history, a family positive family history in 56% of cases, while in the low penetrance group, the frequency was 25%. Regarding the clinical manifestations, abdominal pain was significantly more frequent in patients carrying high penetrance mutations, 84% versus 36%, while non-specific manifestations such as oral apoptosis were more frequently reported in patients carrying low penetrance variants. In regard with prognostic features, mutations involving cysteine residues, so high penetrance mutations, and the presence of the abdominal pain during attacks at disease onset significantly correlated with the development of pathologic proteinuria. Lymphadenopathy during attacks correlated with the development of reactive amyloidosis over time, and the discontinuation of biologic treatment because of the onset of secondary inefficacy was correlated with the development of amyloidosis over time and pathologic proteinuria. The use of colchicine was negatively correlated to the development of pathologic proteinuria. In these further pictures, you can see the frequency of the different therapeutic regimens in our patients according to the age at disease onset and according to genotype. More recently, we reported in the study the role of colchicine treatment in patients affected with TRAPS, and you can see we observed a complete response in about 10-12% of patients, a partial response to colchicine treatment in about 60% of patients, and a lack of response in about 30% of patients. Our study suggests that colchicine in TRAPS patients may be used in patients carrying low penetrance mutations who display a milder phenotype and a low rate of reactive amyloidosis. Going on, hyper-IgD syndrome is a further autosomal recessive autoinflammatory disorder. Patients usually show abdominal pain, gastrointestinal symptoms such as vomiting and diarrhea, cervical lymphadenopathy, hepatosplenomegaly. Patients may present also bipolar apoptosis, and for this reason, hyper-IgD syndrome is a differential diagnosis with the PFAPA syndrome, but also with Behçet disease. Serosal inflammation is quite uncommon. Patients may also show skin rashes. Usually, the disease onset during the first even year of life, and the fever attacks have an intermediate duration from 4 to 6 days. These are the clinical guidelines for performing genetic tests for hyper-IgD syndrome. And as you can see, the guidelines suggest to perform genetic tests only in case of onset of symptoms below the age of 5. And since today, adult onset hyper-IgD patients have never been reported, and hyper-IgD syndrome can be diagnosed during adulthood only due to a prolonged diagnostic delay. Finally, the cryopyrin-associated periodic syndromes are 3 phenotypes of increasing severity, from the mildest, the familial cold autoinflammatory syndrome, to the intermediate, the Muckle-Welch syndrome, to the most severe phenotype, the Nomid-Chinka syndrome. The three phenotypes shares the urticarial skin rashes, the fever, the weakness, the bone pain, the headache, inflammation of the eye and muscle pain. In addition, patients with the Muckle-Welch syndrome may develop over time a reactive sensorineural hearing loss and progressive blindness, and Nomid-Chinka syndrome may develop over time brain atrophy, mental retardation due to chronic meningitis, and also bone deformities. The symptoms, the clinical manifestations usually are triggered by a generalized cold exposure of the patients. For this reason, the cold stimulation time test with the eyes of the skin usually do not evoke the onset of urticaria, differently from other kind of cold urticaria. And in the picture, you can observe the most peculiar clinical manifestations, from the skin rashes, the bone deformities, the eye inflammation, the sensorineural hearing loss. Hereditary periodic fever syndromes may usually overlap, but there are many aspects that can help us to establish a differential diagnosis. For example, the ethnicity of the patients, the family history may suggest an autosomal recessive or dominant transmission, but also the age at the disease onset, because some of these diseases may onset only during childhood. For example, hyper-IgD syndrome, and other disorder may onset also during adulthood, as in the case of familial Mediterranean fever and Relapses syndrome, but also the duration of fever attacks and the presence or the absence of peculiar clinical manifestation. Finally, also the response to specific treatments may help us to establish a proper differential diagnosis. The differential diagnosis of periodic fever syndromes can be also complicated by other entities, such as PFAPA syndrome. PFAPA, the acronym PFAPA derives from the most common clinical manifestations, such as periodic fever, stomatitis, pharyngitis, cervical adenitis. It is typical in patients with PFAPA syndrome, the response to a single administration of glucocorticoids and the regular intervals between fever attacks, which is called clockwork periodicity, that is quite common, especially in children. Over the past year, recent medical literature has involved dozens of suspected cases of PFAPA syndromes also in adults. This is our experience. In this manuscript, we reported 30 adult patients affected with PFAPA. We reported, you can observe briefly the most common clinical manifestations in adult patients. Interestingly, we reported that 20% of adult patients with a suspected PFAPA had suffered from a PFAPA syndrome also during childhood, and in most of these cases, the disease had reappeared during adulthood after disappearing after tonsillectomy during the pediatric age. In this further manuscript, we compared PFAPA patients between children and adults. As you can observe, pharyngitis is more common in children than adults. Adult patients are usually oligosymptomatic, and regular intervals between fever attacks can be observed mainly in children. Adult patients are less responsive to glucocorticoids than children. And recently, we have published the only diagnostic criteria for diagnosing PFAPA during adulthood. Our criteria suggest that it is possible to diagnose PFAPA in adults when the patients present recurrent fever attacks with erythematous pharyngitis and or cervical lymphadenitis. Is mandatory the presence of increased acute phase reactants during attacks, and it is mandatory the presence of symptom-free intervals between attacks. Laboratory analyses are not useful for diagnosing autoinflammatory disorders, but we know that autoinflammatory diseases never present with normal acute phase reactants during fever attacks. Serum amyloid A is not useful to diagnose this kind of diseases, but it is relevant to monitor the response to treatment in patients with autoinflammatory disorder. The treatment relies on the use of interleukin-1 inhibitors that are able to control symptoms associated with acute attacks, are able to prevent recurrent attacks, but mainly are effective in preventing the development of reactive amyloidosis over time, are effective also in patients who have already developed a reactive amyloidosis over time. As you can see in this family of patients with Maple-Welch syndrome, you can observe in the pictures the improvement of kidney function over time during treatment with canakinumab and the decrease of proteinuria over time. In this regard, we have recently reported evaluated the drug survival of interleukin-1 receptor antagonist anakinra and canakinumab in monogenic autoinflammatory diseases. The primary aim of our study was to evaluate the overall drug retention rate of anakinra and canakinumab in patients with monogenic autoinflammatory disorders. The secondary aims were to evaluate the impact of different lines of biologic therapy, of adverse events, and of the penetrance of mutations of anakinra and canakinumab drug retention rate. Finally, to find any potential predictive factor responsible for drug discontinuation. The ancillary aims were represented by a recording of safety profile and exploring glucocorticoid sparing effect. Briefly, the demographic characteristics of our patients. We enrolled 78 patients with periodic fever syndromes. Briefly, our results, the estimated drug retention rate of anakinra and canakinumab at 12, 24, 36, and 48 months of follow-up was 75, 69, 64, and 51% respectively, without showing any difference between biologic naive patients and those patients previously treated with other biologics. Significant differences in terms of drug survival were observed between patients experiencing adverse events and those without adverse events. Moreover, patients carrying high penetrance mutations displayed a significantly higher drug retention rate of the interleukin-1 inhibitors compared to those patients with low penetrance mutations. The occurrence of adverse events was the only variable associated with a higher risk of treatment withdrawal, and anakinra and canakinumab displayed a significant glucocorticoid-sparing effect. Indeed, a significant reduction in the number of patients requiring a co-administration of glucocorticoids was observed. About 74% of patients were able to discontinue glucocorticoids during treatment. Briefly, you can observe the reasons for the discontinuation for both agents, anakinra on the left and canakinumab on the right picture. The study, regarding with our study conclusion, we observed that anakinra and canakinumab displayed a satisfactory drug retention rate while reducing the glucocorticoid intake. Anakinra and canakinumab had an excellent drug retention rate in these kind of diseases, and their survival is not influenced by the different line of biologic therapy. And these kind of agents display an excellent safety profile. In conclusion, recurrent patients can be suspected with autoinflammatory disorders when they display recurrent inflammatory or fever attacks. The presence of a positive family history may be relevant for diagnosing, for suspecting an autoinflammatory disorder. The presence of acute markedly increased acute phase reactants is mandatory, especially during fever attacks, but can be helpful also the presence or the absence of peculiar clinical manifestations. These patients usually are not responsive to traditional immunosuppressive agents, and it can be useful to suspect this kind of diseases the response to specific treatment, such as the response to colchicine for suspecting familial Mediterranean fever, and more in general, the good response to interleukin-1 inhibition. I thank you for your kind attention.
Thank you very much, Professor Cantarini. It was elegant and comprehensive and incisive as well. You brought this difficult topic to the minds of rheumatologists attending the meeting. Thank you very much for this presentation. We have 3 questions. Number 1 is by Dr. Mohammed Nabil from Beni Suef University. Thank you, Dr. Luca, for this elegant presentation. What is the management of colchicine-resistant protracted febrile myalgia in FMF patients? I think this was covered, but I leave the question to Professor Cantarini.
In our experience, we are used in this kind of subjects to increase colchicine up to 2 or 3 milligrams, but in most cases also high dose glucocorticoids can be necessary. In patients, however, in patients displaying a more severe phenotypes, we are used also to add an interleukin-1 inhibitor and to maintain also colchicine treatment. The only case in which we do not use interleukin-1 inhibitors is with patients with a chronic arthritis. In these subjects, we go on with colchicine from 1 to a maximum of 2 milligrams per day, and we add usually TNF alpha inhibitors for treating chronic arthritis, but especially in patients with an axial spondyloarthritis.
Okay. The second question is submitted by Manal Abdelmenem, Professor Cairo University. She loves the question as a topic in how serum ferritin in FAPA behaves. How does it behave in FAPA?
No, in PFAPA, usually serum ferritin levels are normal. It's not used for diagnosing PFAPA and to monitor the response to treatment in PFAPA syndrome. But FAPA syndrome is usually a mild disease in children. In adults, we have many patients with a severe disease course, and in these kind of subjects, we need to start treatment with biologic agents, but we usually test only acute phase reactants, traditional acute phase reactants, such as the C-reactive protein and ESR.
Okay, the third question relates to the second one. If serum ferritin increases with FAPA 2000, similar to Still's disease, I think the answer was
not in my experience and our experience, but I can see one more question maybe.
No, these were three questions.
From Dalia Fayetz
Dalia.
on how to treat FMF patients complicated with amyloidosis and not responsive to colchicine.
Okay.
I can say that in case IL-1 inhibitors are not available, you have to choose IL-6 inhibitors. We never use tumor necrosis factor alpha inhibitors in FMF patients, and we are used to use interleukin 6 inhibitors instead of IL-1 inhibitors in case of the development of a secondary inefficacy over time, of allergic reactions to anakir, but in some we have observed an excellent response to tocilizumab, for example.
Okay, thank you, Professor Cantarini. I think we are done now. We move to the third presentation, and we thank you very much for your wonderful presentation.
Thank you very much for the invitation. It has been a great pleasure.
The pleasure is all ours. Thank you. The third presentation now we start, is on chondrocalcinosis, presented by Professor Thomas Bardin, professor of Paris University, Hôpital Lariboisière. Thomas Bardin, or Professor Bardin, is a world-class figure in chondrocalcinosis, as well as many other diseases. He used to be, or he is the convener of most important international meetings discussing gout and emanating guidelines and recommendations for the management. He is prolific in his contributions to book chapters and research papers. He's also a wanderer, working in France, in the States for a while, in the South, in Vietnam, in Caledonia. He has been propagating his knowledge to all corners of the globe. He also likes to be presented as a friend of Egypt. So we are all anxious to listen to his presentation on chondrocalcinosis.
You hear me?
Yes. Did you?
Okay.
Did you hear my introduction?
I did, and I thank you for that.
Thank you. Thank you for accepting our invitation and providing us with this valuable piece of information.
I would first like to thank the organizing committee for this nice invitation. I'm very sorry not to be physically present in beautiful Alexandria, but I hope it will be possible one day.
Yeah, let us hope for that.
Yeah.
We are most welcome in Alexandria and any place in Egypt. You are a great friend.
Okay, chondrocalcinosis is a term which refers to calcium pyrophosphate deposition disease. And this disease is due to the deposition of calcium pyrophosphate dihydrate crystals in the mid-zone of articular cartilage, as you can see on this ultrasound view, and in the fibrocartilage. And here are some of these crystals in the synovial fluid with their characteristic appearance. There has been some EULAR recommendation on terminology, which were first presented at the EULAR meeting of 2010 in Rome. So we call the crystals calcium pyrophosphate, which is abbreviated in CPP. The deposition of this CPP is abbreviated as Cppd, and chondrocalcinosis refers to the demonstration of calcium crystal in the cartilage, usually by imaging or by pathology. As you know, the disease has several clinical presentations. The most common is asymptomatic Cppd. Pseudo-gout is a confusing term, especially for the patients who do not understand if they have gout or another disease. So it's better to call it acute CPP crystal arthritis. Pseudo-OA should be replaced by OA with Cppd, and pseudo-RA should be replaced by chronic CPP crystal inflammatory arthritis. About the pathophysiology of CPP crystal deposition, this is due to an increased calcium over pyrophosphate product in the cartilage. And early work in the early 80s has shown that the concentration of pyrophosphate in patients with CPPD is increased in the cartilage, but usually in the cartilage only. And there is no systemic increase except in a very rare disease, which is hypophosphatasia. So this has led to look at the perichondrocyte metabolism of pyrophosphate. And at first, we only knew that there were two important ectoenzymes. That mean that they take their substrate outside of the cell and they release their product outside of the cell as well. The first one is the nucleosine triphosphate pyrophosphohydrolase, which is now frequently called PC1, which is responsible for the hydrolysis of ATP into pyrophosphate and AMP. And the second one is the alkaline phosphatase, which is also an ectoenzyme and which catabolizes pyrophosphate into phosphate. And in the early 2000s, the Anc Transporter was described. The description of this transporter is important because pyrophosphate is abundantly produced inside the cells, but it has been known for years that it cannot cross normal cell membranes. So it needs this transporter to cross the membrane. And this transporter was identified following the study of Anc mice for ankylosis. This group of investigators found that found the gene responsible for this ankylosing articular disease in mice, and they found that it was a membrane transporter of pyrophosphate. And as you know, pyrophosphate is an inhibitor of apatite formation and bone formation. And these mice had an inactivating mutation, which resulted in a decrease of extracellular pyrophosphate and therefore into apatite mutation. And I guess that most of you know that in following this work, some mutation of the Anc gene has been reported in families of chondrocalcinosis. And these mutations are different from the Anc mouse mutation, in that it is an activating mutation which induce extracellular pyrophosphate in the cartilage, increasing the calcium pyrophosphate product and resulting in CPP crystal formation. As you know, familial chondrocalcinosis is rare, and CPPD is mostly primary or sporadic and related to the age. And some work have shown that probably the Anc transporter also played a role in the sporadic most frequent CPPD. It has been shown by Abhishek that this sporadic CPPD associates with some Anc polymorphism, and it has been known for years that TGF-beta is increased in the synovial fluid of CPPD patients, and in vitro work have shown that it increases Anc activity and also PC1 expression, leading to increased pericellular pyrophosphate concentration. In terms of etiology, CPPD can be a familial disease, which may be related to Anc mutation, but also to osteoprotegerine mutation, and probably to many other mutations, as in our lab, we are frequently asked to test for these two genes in familial CPPD, and quite frequently we find no mutation. And it is known that there are some other loci and unknown genes. It can also be a secondary disease. It is well known that it can occur during hyperparathyroidism, the primitive form, also in hypocalciuric hypercalcemia, sometimes called Mark's disease, in hemochromatosis, in hypomagnesemia, and especially in Gitelman syndrome. And Cornea has recently released a very nice article of a large series of Gitelman syndrome patients with CPPD, and also in a rare disease, familial hypophosphatemia. But most of the CPPD disease we see in the clinic are primary, and these are a disease primarily of the elderly. Indeed, the prevalence of CPPD increases with age, and many studies have shown the same thing, and you see in this one. But when you reach, for example, 80 years of age, you have almost one chance over 5 to be diagnosed with CPPD, whereas the disease is very, very rarely seen before 65 years of age. So it's important to keep that in mind, that CPPD in young patients should let us look for familial disease, which starts early, and secondary diseases, especially hemochromatosis, hypomagnesemia, etc. Primary hyperparathyroidism is most frequently seen in elderly women, and I believe that even in the elderly, we should look for primary hyperparathyroidism. And I should also stress that it's uneasy to diagnose a familial disease when the beginning of it is at an old age. And there are some nice Spanish papers which have shown that even in apparently sporadic CPPD, there was about 20% they could trace to a familial disease by very straightforward and deep investigation. How do you make the diagnosis of CPPD? Well, the gold standard is to identify crystals in the synovial fluid during a crystal-induced attack. And you know that pyrophosphate crystals have squared rands, ends weak and positive birefringence, and can therefore be easily differentiated from the urate crystals. These are these typical square hand crystals, and you can see that many of them are not birefringent. This one is birefringent, but for example, if you look at this one, you see nothing when on the dark field. So when you look for CPPD crystals, it's very important to start with regular light. You see them much better with regular light rather than with compensated light microscopy. Another way of diagnosing CPPD is to demonstrate chondrocalcinosis, which is a feature almost specific for CPPD. There can be some mixed deposits with hepatite and CPPD, and the only disease I know of which can mimic CPPD by chondrocalcinosis is primary oxalosis, which is very rare and in which articular deposits develop only in patients at the stage of renal dialysis. So this chondrocalcinosis can be shown by plain radiography. You see here the meniscus calcification, and you have also some calcification in the articular cartilage. The knee is the best joint for screening, followed by the wrist. There has been a nice study by Abhishek, which has shown that the wrist was also a very frequent site of CPPD deposition. CT scan is, of course, a little more sensitive than plain radiography, but is mainly interesting for chondrocalcinosis of the spine. I will come back to that later. And ultrasonography has a great sensitivity, great availability. Most of rheumatologists now perform ultrasonography, which is an excellent tool for diagnosis of crystal-related diseases. You can see here on this femoropatellar view the presence of this material in the middle layer of the cartilage. This is very, very typical. But there are some pitfalls in ultrasonography. Not every joint can be scanned by ultrasound scan, and diagnosis is highly dependent on the expertise of the observer. Ultrasonography is especially useful at the wrist, showing these deposits in the triangular ligament in the fibrocartilage, and you can see an example here where the X-ray was negative and the ultrasonographer disclosed these typical deposits. So ultrasonography is really of great help for the diagnosis. Now the clinical presentations. Well, as you know, most CPPD patients have no symptoms related to their crystal deposits. It's the finding of chondrocalcinosis on an X-ray, which has been done, for example, for osteoarthritis of the knee, which allows us to say that this patient also has CPPD. The most typical presentation is the acute microcrystalline arthritis, which was called pseudo-gout because it has the same features of the gouty arthritis. It's a microcrystalline arthritis with pain, swelling, often fever, always elevation of the CRP. And the two features which are characteristic of acute microcrystalline arthritis are their rapid onset. This is also true in CPPD as in gout. The pain and swelling become they have their highest level within 24 hours. And the spontaneous resolution, which is very characteristic of gout, and this is less clear in CPP arthritis, as these tend to last for longer and become subacute or even chronic in a number of patients. As you know, the two joints more frequently involved are the knee and wrist, but any joint can be involved. And in this instance, the best way to diagnose is to aspirate the joint fluid, look at it under a microscopy, and identify the CPP crystals. In addition, this aspirate will allow to rule out the main differential diagnosis, which is septic arthritis, which can also, as you know, coexist with CPP crystal arthritis, so that the bacteriological studies of the fluid should always be performed. Cppd management, when we did these EULAR recommendations, there was a large consensus over the fact that joint aspiration and intra-articular injection of long-acting glucocorticosteroids is the main way of treating these acute flares. Oral NSAIDs and maybe colchicine are also effective, but the patients are usually elderly and their use is limited by toxicity in this type of patients. And you could also use a glucocorticoid at a fairly high dose, 30 milligrams per day, but very rapidly tapered. And this can be effective when you cannot inject or give NSAIDs or colchicine. We have some experience in some patients which are refractory to these standard measures, and using Il1 blockers, this is also usually very effective in the acute arthritis of CPPD as it is in gout flares. Osteoarthritis with CPPD is another pattern, and this is a fairly controversial relationship. We know that calcium crystals, mainly BCPs, but also CPPDs, are almost constantly found when you look at the remnant cartilage after joint replacement. So at the late stage of the disease, they are very frequent. We also saw that CPPD can stimulate the synovium to lead to secretion of protease, so it could play a pathogenic role. However, the presently available studies have failed to show worsened outcome in OA patients with CPPD than in patients without. So we do not know exactly what is the responsibility of CPP crystals in OA development or worsening. However, as clinicians, we know that some atypical sites of non-traumatic OA are frequent in CPPD. For example, the shoulder-centered osteoarthritis, the non-traumatic wrist osteoarthritis, slack wrist, isolated STT OA without trapeziometacarpal OA, MCP OAs, and also ankles which have not been traumatized. And in patients with these atypical features, we systematically look for CPPD and frequently, not always, but frequently find some chondrocalcinosis. This is an example of this radiocarpal OA with some incrustation of the scaphoid into the radius, slack wrist, very severe STT arthritis without trapeziometacarpal arthritis, and these MCP OA, which are rare in the regular form of OA. You can see that sometimes in very severe cases in patients who have used a lot their hands, in farmers, for example. But when you see that, you should look for CPPD and hemochromatosis, of course. CPPD can also associate with destructive arthropathies in elderly women usually, which can be multiple and lead to really very big handicap. You have some example of the knee with this destruction of one of the femoral plateau, this patellofemoral involvement, which is very typical of CPPD, with this reciprocal indentation of the two articular surface. You can see the same thing at the spine, and here this destructive arthropathy of the hip with a collapse of the femoral head. And Charles-Joël Menkes, years ago, has shown also an association with of rapidly destructive osteoarthritis of the hip with CPPD. This occurs in elderly patients, and more than half of them have CPPD of the knees, for example, of other joints. So there is no specificity for the management of OA with CPPD. Total joint prosthesis are, of course, indicated in severe or destructive arthropathies. Another very interesting presentation for rheumatologists is the chronic CPPD crystal inflammatory arthritis. This can present like polyarthritis, and the differential diagnosis is rheumatoid arthritis. So clues for the diagnosis of CPPD-induced polyarthritis is the fact that the patient is an elderly, that you can find some chondrocalcinosis in some joints, and also the radiological appearance of the affected joints, where you don't see rheumatoid arthritis or subchondral osteopenia, but you can see that the limits of the epiphysis are not blown out. They are, in contrary, underlined by thin sclerosis. And this is a very important clue for the differential diagnosis. We also know that proximal involvement can mimic polymyalgia rheumatica, and there has been a number of papers about that. When you see polymyalgia rheumatica, which tends to relapse when you lower the steroids, you should look for chondrocalcinosis. Where now with the use of PET scan, the definite diagnosis of polymyalgia rheumatica is much easier. How do you treat these patients? Well, most of us use low-dose steroids, but I must say that patients tend to be steroid dependent. You have to increase the doses, and in the elderly, it's not completely acceptable with the risk of osteoporosis and fractures, for example. Second-line therapy include methotrexate. We had great hope when an open Swiss study was published in AR a few years ago, but the same investigators in Geneva made a placebo-controlled study which was negative. Plaquenil has been shown to be effective in a placebo-controlled very old trial, but I guess that nobody really believes this trial and very few of us use it. When you want to spare steroids, you can use Il1 blockers. In my experience, it works less well in chronic inflammation related to CPPD than in the acute flares, and I had a number of failures. But this can be useful, despite the fact that one injection a day is hard to tolerate by these elderly patients, especially with the skin reactions, which are so frequent. So we tried tocilizumab and had a very good experience in chronic CPPD inflammatory disease. This was published as a pilot study, our first 8 patients. I must say that we had a number of serious side effects, a few infections, but it's undoubtedly very, very efficient. And finally, I would like to tell you a little about the spinal manifestation. We did a study a few years ago with Abdelaziz Moshrif, one of our Egyptian colleagues, when he visited us in Lariboisière Hospital in Paris. And most of what I'm going to present comes from this work. So Cppd can deposit in almost anywhere in any musculoskeletal structure of the spine. It can be seen in intervertebral disc, in intraspinal ligaments, in cartilage of the vertebral plates, or the interapophyseal joints. But you can see that only with a CT scan, which is much more sensitive than the plain radiograph. For example, you see here this intervertebral disc peripheral calcification, and here you can see also some calcification in the ligament. Again, this peripheral, mainly peripheral deposits, and also in the sacroiliac joint, where you see much better with the CT scan. The deposits at the craniovertebral hinge are very frequent, and these very typical deposits in the retroendotoid ligaments. You see this typical aspect of linear rail-like appearance in the transversal and the sagittal view. These are very specific of Cppd, and several studies have shown that it was this ligament was one of the most frequent sites of Cppd deposition, even more than the knee cartilages. These deposits are most often asymptomatic, but they can cause the Crohn-Dance syndrome, which is a very severe acute cervico-occipital pain, which can last a little longer, and there are subacute and even chronic forms. What is characteristic is the impairment, total impairment of rotations of the head, which points to the craniovertebral, craniocervical hinge. And of course, there is some elevated CRP and ESR, maybe some fever. This is a very severely painful syndrome. The problem is that it can be due either to CPP or to BCP crystals. It's most frequently CPP crystals, and clues for the diagnosis of CPP is the fact that it occurs in patients quite old. These linear deposits I showed you in the retroendotoid ligament are specific, and in most of the time you will find some chondrocalcinosis of some intervertebral disc. I can show you, on this one you can see that there is here some chondrocalcinosis. There is here also on the lateral joints, and also in peripheral joints. And another thing which differs with CPPD, with BCP, excuse me, is that the deposits will not decrease during the acute flares, whereas in BCP-induced Crohn-Dance syndrome, if you repeat the CT scan a few weeks after the attack, you will see that the deposits have usually decreased. These manifestation at the craniovertebral hinge can also be some erosions of the ondotoid dance, and this can lead to some fracture or complete lysis of the dance. And in a few cases, we observe these destructive arthropathies very difficult to treat because no surgery is possible. The deposits in the intracannular ligaments are also best shown by CT scan. They are usually small and of no clinical importance, but they can be compressive at the foramen magnum with bulbomedular compression, at the cervical or thoracic spine with some medular compression. And I would like to finish this talk by insisting on the ascites of Cppd. This has been described a long time ago, in the 80s, mainly by French investigators. Involved patients are elderly, as usual with Cppd. They have an inflammatory spinal pain, which can be induced by Cppd crystals in the disc, causing some acute flares. But here it's different. It's an inflammatory spinal pain which lasts. It's a subacute or chronic. They have an increased CRP, and these destructive ascites. I showed you this X-ray before with the analogy of the femoropatellar involvement, and these ascites, destructive ascites, can be plurifocal. So when we, with Abdelaziz Moshrif, we reviewed our files at the Lariboisière Hospital, we were able to describe several stages which may be the natural course of the disease. So the less severe involvement that we saw was this inflammation of the vertebral plates, a modic one type of discovertebral involvement, which can be multiple, just as in this patient. This is not ascites because the intervertebral disc is not involved, but this is ascites. You see that in addition to this inflammation of, this is a T1, this is a T2 of the vertebral plates, there is some inflammation with gadolinium enhancement and T2 hypersignal of the disc itself. So this is the first stage of ascites. The second stage is the same features, but with some soft tissue thickening, which takes the gadolinium. And you can see this, well, it's moderate, but it's there, a soft tissue thickening. On stage 3, you can see some erosions of the vertebral plates, which are, of course, most visible by CT scan, but you can see also on T1, and with this enhancement of the disc and the erosion by gadolinium. This is the erosive state. And this is the stage 4, last ultimate stage, in which you have a disc destruction and cavitation with liquid collection. And this is, of course, very bothering. This is another patient who has this same stage 4, and you see that it has it on 2 sides, so it can be multiple. So, of course, the main differential diagnosis is the infectious ascites. And again, there are a number of clues. Patients are elderly, they have peripheral chondrocalcinosis or chondrocalcinosis of the spine. They may have a plurifocal involvement, but this can also be seen in septic ascites. And they have usually a moderate soft tissue inflammation. But in many cases, we kept some doubt with a septic arthritis, and in these cases, we performed transcutaneous disc biopsy, which did not show any microorganism, except in one patient who had tuberculosis, and we were very happy not to have missed the biopsy. So please perform the biopsy if you have the slightest doubt with infectious discitis. The sacroiliac joints can also be involved with some deposits and acute sacroiliitis. And in our series of patients, we saw one case of ankylosis and also one case of destructive sacroiliitis in a patient who also had Cppd discitis. You should know that there are some extra-articular deposits, these tophaceous deposits, which are frequently seen in the pulp of the fingers. They can also be seen in the vicinity of the temporomandibular joints. You can also find some deposits in the eye, in the retina. It's not so rare if you look for it. And this is the deposits in the tendons. You see that it is very different, typically, of the BCP calcifying tendinitis, because these deposits are very thin, they go very deep into the tendon, and usually they don't start at the site of the bone attachment of the tendon. So I'm now finishing, and in summary, of course, Cppd is a very important arthritis, which is very much neglected, especially by the pharmaceutical industry, because it's a disease of the elderly, and with the prolongation of our life expectancy, it becomes more and more frequent. It has been called by Dan McCarthy in the early days a great simulator, and this is true. It can simulate, in particular, rheumatoid arthritis, polymyalgia rheumatica, septic discitis, but I gave you the clues for a proper diagnosis. Progress recently made have concerned the pathophysiology with the identification of this Anc Transporter, which could become a target for a pharmacologic treatment. The imaging with the ultrasound, I did not spoke about the dual energy computed tomography, which has some applications in Cppd as in gout, and the use of biologic anakinra tocilizumab to treat the inflammation induced by the crystals. But we still, in opposite to gout, have no ways of dissolving the pathogenic CPP crystals, and we need the industry to get interested into this therapeutic need, which is important. Thank you very much. I'm finished.
Thank you very much, Professor Bardin. This was extremely enlightening, and in French, très exquis. We have to. Very nice. We have two questions, although we are running out of time, from Dr. Manal Hilal. She thanks you for the elegant talk, and she asks, is there any role for prophylaxis to avoid recurrent acute flares?
Oh, yes. I forgot to say that. I think it was on the slide. It's a very old study in the 80s, which has shown that in patients with frequent relapses, more than 3 acute flares a year, small dose of colchicine was helpful, and it reduced the frequency of flares by a factor 2. Dr. Spielberg published that in the 80s in the Journal of Rheumatology. So I use it, of course, in frequently flaring patients. Sorry to have missed that.
Okay, the last question from Dr. Dalia Faiz. In all patients with renal impairment and hyperparathyroidism, what is the best treatment for CPP, inflammatory arthritis? What would you choose?
The association is with primary hyperparathyroidism. Usually in hyperparathyroidism secondary to renal failure, there is no increase of CPPD because calcemia remains normal or low. And a number of studies have been published which have shown that the CPPD prevalence in renal failure patients was in a similar range as in the general population. So, still a patient with renal failure can have a CPPD manifestation. I think that the acute arthritis are best treated, as in everybody, by joint aspiration and steroid injections. The chronic inflammation is treated usually by low-dose steroids.
Okay, thank you very much, and we're looking forward to welcome you and host you in Egypt next year. Hopefully this will come true.
Hopefully it will be a great pleasure for me.
Okay, looking forward. Bye-bye. Our last speaker in this part of our review course is Professor Mervet Matar. She is a professor of hematology in Cairo University, and she's considered among the pioneers of hematology in Egypt as a whole. And she has been a leading figure in her field and a promoter of interdisciplinary activities and research, and that's where we ask her to present her talk on immunothrombosis. It's noteworthy that last year she was decorated with the National Prize of Merit for achievements by women or female doctors, and this is something to brag about, I'm sure. Dr. Mervet will introduce this topic, which is increasingly gaining attention, the interplay or intermingling of the immune system with thrombosis, with the reciprocal activation on both parties. Dr. Mervet, you can proceed, and we're sorry for keeping you waiting till now.
Good evening,
Welcome, Dr. Mervet.
It is my pleasure and honor to be sharing in such a prestigious meeting. I thank Dr. Gafar Ragab for inviting me. We are going to discuss immunothrombosis. So, what is immunothrombosis? It is an intrinsic effector pathway of innate immunity triggered by pathogens in injured cells to reduce the spread and survival of the invading pathogens. It results in an innate immune response induced by the formation of thrombi inside the blood vessels, particularly microvessels. The activated neutrophils are giving neutrophil extracellular traps because they may abandon their cellular integrity and form the so-called nets to eliminate pathogens by immobilization and extracellular destruction, thereby preventing bacterial dissemination. So why are they formed? Larger microorganisms, which are not readily digested, lead to blocking of phagocytosis, and so they force the neutrophils to commit to net formation rather than phagocytosis. Other stimuli, other than microorganisms, include nitric oxide, urate crystals, autoantibodies, and pro-inflammatory cytokines such as interleukins, interleukin-1 beta, interleukin-6, interleukin-8, tumor necrosis factor alpha. There is an interaction of neutrophils with activated platelets or endothelial cells. Not just the neutrophils are implicated in mitosis. So the activation and release of neutrophil extracellular traps is called mitosis. This is the process. It is supported by immune cells and specific thrombosis-related molecules because it generates an intravascular scaffold, as you see, that facilitates the recognition the containment, and the destruction of pathogens. Within this process, there is protection of host integrity, and there is no major collateral damage to the host. However, this is not the case in every case. We can talk about thrombo inflammation, which is probably immunothrombosis out of bounds. This is a bomb that is going to explode. As you can see, if there is an insult, especially in the microvessels, the thromboinflammation refers to a process in which inflammation and thrombosis coexist within microvessels in response to harmful stimuli. And in this case, not only immunity against the pathogen occurs, but also harm to the tissues by the hyper-interaction of neutrophils, platelets, endothelium, monocytes, dendritic cells, lymphocytes, and others, causing inflammation rather than immunity alone, with hyperstimulation of neutrophils and neutrophil extracellular trap formation. It is seen in many inflammatory and thrombotic disease states, such as sepsis, trauma, atherosclerosis, and of course autoimmune disorders, which we are going to discuss in detail, for example, the antiphospholipid syndrome. Other problems, paroxysmal nocturnal hemoglobinuria, for example, and other thrombotic microangiopathies, the same process may be implicated. So what is the mechanism of net formation? Nets are nets. They are net-like complexes, as you can see, consisting of chromatin DNA, histones, and neutrophil granule proteins, which are released in the extracellular plate space. Among the granules that can be released are germicidal proteins from neutrophil granules, such as myeloperoxidase, neutrophil elastase, cathepsin, and gelatinase. There are two types of DNA, the nuclear DNA, the chromatin DNA that can be produced inside the net, and also the mitochondrial DNA, or the mitochondrial net. So nets also bind not only to the pathogen, but they bind to the von Willebrand factor from endothelial cells, platelets, subendothelial connective tissue, serving to ensnare the platelets, leading to aggregation and platelet plug formation. Here we are trying to make the bacteria not propagate into other tissues, and so they form platelet aggregation and platelet plug formation, the so-called platelet tethering. The specific histones secreted in nets are namely H3 and H4 mainly, and they cause a direct trigger of platelet activation. And they also behave as damage-associated molecular patterns, part of innate immunity, and they can activate the complement pathways. So this is just a figure. If there is a pathogen, then there is stimulation of neutrophils causing netosis, stimulation of activated platelets with P-selectin stimulation causing adhesion, and also the interaction with the endothelial von Willebrand factor and the interaction with complement stimulation. All that can cause stimulation of the coagulation pathway and also stimulation of monocytes by this process with the formation of dams and microvasculars and antigen presentation to other immune cells. And this results in inactivation of anticoagulants, natural anticoagulants, platelet adhesion and activation, and contact pathway and extrinsic pathway stimulation of the coagulation cascade. And here we have blood coagulation and immunity at a glance. They act together, they are stimulated together to try to cope with the pathogen and make the pathogen still and stop the propagation of the pathogen elsewhere in the body. What has this to do with immunity and autoimmunity? Immunity we just mentioned. How about autoimmunity? Nets can cause perpetuation of inflammation. They can cause activation of the adaptive immune system, as in lymphocytes. They can activate the complement system and the inflammasomes. And inflammasomes are important for pyroptosis, which was one form of cell death dependent on caspase-1. And they can act as damage-associated molecular patterns on their own, not only for innate immunity, but also for inflammation. How about the platelet? Now, the platelet was once seen as a small creature, one form of cell, which is responsible of stopping bleeding. However, the activated platelet is something else. The activation of platelet receptors on the surface triggers pathways that promote inflammatory signaling or facilitate adhesion. The interactions between platelets, leukocytes, endothelial cells, and coagulation factors, and other platelets will get together the immune system and thrombosis. Pro-inflammatory molecules that trigger platelet signaling pathways directly facilitate changes to platelets, including hyperactivity and increased procoagulant surface area and increased formation of intercellular complexes. We look at the platelets, they contain dense granules, they contain alpha granules, which can, on activation, can be pro-inflammatory. They also contain certain receptors on their surface. And looking at these platelet receptors, it has receptors associated with antigen presentation, which can stimulate other immune cells, for example, the lymphocytes. They have activation modulating receptors that can cause activation of other platelets and other cells. They have adhesion receptors. Of course, P-selectin is the most famous, which can cause adhesions of more and more cells. They have the integrins, which we are going to discuss in detail in autoimmunity, and they have G-protein coupled receptors. So this is a figure of what happens. There is invasion of the bloodstream, for example, by bacteria, and these bacteria are not only attacked by the neutrophils, but they activate the platelets, and once the platelets are activated, they migrate and collect bacteria and present them to neutrophils. And here the neutrophils are stimulated into phagocytosis, but not only that, they are also stimulated into netosis, trying to kill bacteria. And within this process, there is activation of the coagulation system and tissue factor at the endothelium. And all that results in thrombin formation. And here we end in bacterial trapping and limitation of the pathogenicity, but we also end up with some organ injury. I have to point out here that pyroptosis is of one form of cell death, which depends on caspase-1. And here we mentioned tissue factor. Now, tissue factor is found in an inactive form on the endothelium, but once it is activated, it can cause tissue factor-rich microvesicles. And now we are mentioning the endothelium, the quiescent, nice endothelium. However, it can be more aggressive during inflammation. Let us see. The endothelium contains or has molecules that during the quiescent stage are antiplatelets or anticoagulants naturally. So it has the CD39 molecular pathway that is an antiplatelet. It has nitrous oxide and prostaglandins, which can cause vessel relaxation with an antiplatelet effect and maybe an indirect anticoagulant effect. It has the antithrombin 3, which is an anticoagulant, anti-inflammatory, antiplatelet. It has the thrombomodulin, and together with protein C, it can cause natural anticoagulation, cytoprotection, barrier protection, and it does contain the tissue factor pathway inhibitor, which keeps the tissue factor quiescent. However, with thrombo inflammation, the endothelium becomes stimulated. And so it produces active von Willebrand factor, which interacts with the platelets, making it more active. And it also shows cell surface adhesion molecules. It attracts neutrophils it stimulates the coagulation factor, and it stimulates the formation through tissue factor activation of active thrombin. And active thrombin is very important. It is a very important factor in the formation of the blood clots with fibrin formation and with more and more tethering of platelets. And with platelet tethering, this makes the platelets be attracted more and more to the endothelium, and activation of the platelets through glycoprotein 1b V1X stimulation, and through P-selectin, and through alpha-beta integrin molecules, and through the CD40 ligand, which stimulates, interstimulates the platelets and whatever it is attached to, with accumulation of leukocytes and stimulation of leukocytes and adhesion of leukocytes. And so here we have the bomb again, from a quiescent endothelium to an inflamed, prothrombotic, pro-inflammatory endothelium. I have to point out that activated factor 10, thrombin and plasmin, they also take part in complement activation. And so it is an interrelationship between inflammation and thrombosis. How about monocytes? In response to certain agonists, monocytes and their microvesicles express activated intravascular tissue factor that then initiates the extrinsic pathway of coagulation. And still, this is the crosstalk between immunity and clotting. How about NETs, autoimmunity? NETs are suspected to be involved in the initiation of autoimmune and autoinflammatory diseases. As common denominator, autoantibodies against NET components, for example, against the myeloperoxidase DNA complexes, the citrullinated histones, very famous in rheumatoid arthritis, and the neutrophil elastase. These are features of several systemic autoimmune diseases. And this figure illustrates the relationship between NETs and autoimmunity. So neutrophil extracellular traps are found to be of value in pathogenesis of lupus, of rheumatoid arthritis, of ANCA-associated vasculitis and other vasculitides, and even in gout. And they stimulate macrophages, T cells, dendritic cells, B cells, and so they can induce and can maintain autoantigenicity, complement activation, dam formation, inflammasome activation, and also there is an association with decreased NET degranulation. And so there is NET accumulation, and with NET persistence of these molecules, there is inflammation and autoimmunity causing autoimmune disease. Let us look at lupus. With systemic lupus erythematosus, NETs are detectable in the skin and in the glomeruli of patients with cutaneous lupus and lupus nephritis. Impaired NET clearance by macrophages is there in lupus, and there is persistent presence of antigens for autoantibodies recognizing neutrophil proteins. And there is also higher circulating cell-free DNA levels, which may be associated with active lupus nephritis. There is also a subset of granulocytes present in lupus, which is called the low-density granulocyte subsets. These have an increased spontaneous NET formation. And there is a heightened pro-inflammatory response by interleukin-6A, human necrosis factor, altered phagocytic capacity, enhanced ability to synthesize type 1 interferons with killing of endothelial cells. And look at this figure. Here is the neutrophil, which secretes NETs, and this will cause autoantibody formation against myeloperoxidase, neutrophil elastase, others, which can stimulate B cells to form more and more autoantibodies, immune complexes, kidney destruction, and also involvement of the plasmacytoid dendritic cells, contributing essentially to the dysregulation of interferon alpha, which is critical in lupus patients, and of course, complement activation with platelet stimulation. About ANCA-associated vasculitis, it is characterized by the presence of autoantibodies against the antigens, MPO again, and proteinase 3, found within NETs, which subsequently contribute to vascular endothelial damage by activating the complement system. NETs can be detected by immunofluorescence in the necrotizing regions of vasculitis. Activated platelets can drive complement activation and prime neutrophils to more netosis. Neutrophil degranulation by ANCA results in release of tissue factors and NETs contributing to thrombosis. Excessive activated platelet activation of complement can prime neutrophils for ANCA-induced degranulation. Activated platelets can drive complement activation, and this can be detected frequently. These cytoplasmic enzymes of neutrophil granules are released during cell activation and netosis and induce the formation of PR3 ANCA, as we mentioned, and MPO ANCA, which subsequently contribute to vascular endothelial damage by activating the complement system. A feedback loop in the sense of a vicious circle is created by the fact that P3 ANCA and MPO ANCA in turn induce netosis. So we have a vicious circle of autoimmunity. How about netosis and rheumatoid arthritis? Here, the neutrophil secretes NETs, including neutrophil elastase and peroxidase, causing autoantibodies inside even the synovial fluid. In rheumatoid arthritis, during netosis, neutrophils externalize the citrulinated autoantigens, characteristic of antibodies in rheumatoid. These include citrulinated vimentin antibodies, which are potent inducers of more NET formation. Interleukin 17A and tumor necrosis factor alpha induce netosis in rheumatoid arthritis neutrophils, further inducing interleukin formation, chemokines, and adhesion molecules. And here, inside the joint, there are the fibroblast-like synovites, which can then process and present these citrulinated peptides coming from the neutrophils to human rheumatoid factor antigen-specific T cells, and can activate these T cells. And so the synovial membrane is being attacked. How about platelets? Platelets, again, are found in the synovial fluid in rheumatoid arthritis, but to a lesser extent than neutrophils. They become activated, dysregulated, with increased localized chemokine, cytokine, and growth factor release, and microparticle release, causing acute inflammation, increased localized angiogenesis, increased localized synovitis, increased intercellular complexes. So here the joint is being attacked. The joint synovium is being attacked by the neutrophil, by the lymphocyte, and even by the platelets in an indirect way. Platelets and platelet microparticles are found in arthritic joints, where platelet microparticles and their cargo of tissues, of membrane, of receptors can be internalized by activated neutrophils. Chemokines, cytokines, and growth factors secreted by platelets support the recruitment of inflammatory cells to tissue sites and trigger inflammation. Then there's the platelet P-selectin, which can interact with the leukocytes, causing a leukocyte endothelial crosstalk and cause leukocyte-mediated damage. As you can see in the figure, the activated platelet will not only act on the synovium, but it will act on other platelets by attracting them and activating them. It will act on the granulocyte by NET formation. It will act on the lymphocyte by the CD40 ligand to stimulate these lymphocytes into autoantibody production. And it will stimulate the monocytes, again by P-selectin and ligands, to form more harm to the synovium. Also the integrins, for example, the platelet alpha-2 beta-3 integrin. This signaling in rheumatoid arthritis will interact with the fibroblast-like synovites. And here, the synovites will be more active and will try to kill the cartilage. With alpha-2 beta-3 integrin stimulation, there is collagen-dependent platelet activation with initiation of cartilage erosion and synovial inflammation. How about the CD40 ligand? This is stored in the alpha granules of quiescent platelets and is released onto their membranes and cleaved into the plasma upon activation. It binds to CD40 on lymphocytes and monocytes, and so it tries to stimulate both. This interaction can induce the production of immunoglobulins by the lymphocytes, especially here the IgM rheumatoid factor, and it can enhance endothelial expression of adhesion molecules. How about T cells? We talked about B cells. How about T cells? Platelets can cause modulation of T cell response. Megakaryocytes could develop molecular sensitivity to antigens and preload major histocompatibility class 1 molecules specific to those antigens into newly released platelet fragments. Platelets could then, in turn, deliver antigenic determinants of immunological sensitivity to other leukocytes and thereby modulate T cell responses. And it modulates the Treg control, and we all know that Tregs are very, very, very important for acquisition of self-tolerance. And so the lack of self-tolerance is what it is all about in autoimmunity. How about complement? Chondroitin sulfate A released from platelet alpha granules during platelet activation is a potent activator of complement in the fluid phase, generating anaphylatoxins, inflammatory mediators, and leukocyte activation. Platelet-bound C3 appears to act on the ligand for leukocyte CR1, potentially encouraging platelet-leukocyte interactions. Let's look at antiphospholipid syndrome. Activation of vascular cells, including endothelial cells, platelets, monocytes, procoagulant effects of extracellular vessels, disruption of the annexin A5 shield on cellular surfaces, and complement activation are all there. Antiphospholipid is par excellence a demo of how immunity and thrombosis are together. Antiphospholipid antibodies can activate complement and also thrombosis. C5a engages C5a receptor on neutrophils, resulting in upregulation of tissue factor, which then activates coagulation and inflammation. Do we have proof for that? Yes. In mouse models, antiphospholipid IgG has a prothrombotic effect. The resultant thrombi formed were enriched for citrullinated histone H3, which can be a source coming from the source of NETs. Patients with APS have a decreased ability to degrade NETs. There is a high amount of tissue factor expressed by NETs at sites of inflammation, leading to activation of the coagulation cascade. NETs also activate platelets by binding to histones and factor 12. NETs suppress fibrinolysis by intercalating into the fibrin clots and inactivating the anticoagulant molecule tissue factor pathway inhibitor, which is found in the endothelium. And so here, there is thrombosis induced by antiphospholipid antibodies. How about pregnancy? NETs in the sera of pregnant patients with antiphospholipid syndrome were elevated. Tissue factor signaling through PAR2 is critical in neutrophil activation and trophoblast injury in fetal death. NETs are detrimental to trophoblasts and human umbilical vein endothelial cells. And so here is a link between attack by NETs, thrombosis, and pregnancy loss in antiphospholipid syndrome. Even in autoimmune hemolytic anemia, it is not only anemia. The complement-mediated red cell lysis causes activation of coagulation by exposure of phosphatidylserine, release of tissue factor-bearing microparticles, endothelial cell injury, altered vasodynamics, release of reactive oxygen species, activation of the classic complement pathway by IgM antibody-bound agglutinated erythrocytes binds C1s, extravascular hemolysis of 3B-coated erythrocytes, activation of complement by circulating free hemoglobin. And lastly, COVID. COVID can be, the COVID pathophysiology can be linked to immunity or immunothrombosis. It is a thrombo inflammation unleashed because the pathogen will cause inflammasome production. It can cause activation of the extrinsic coagulation pathway. It can cause activation of contact-dependent coagulation pathway. Pathogen isolation and killing is tried. However, in the process, there is neutrophil stimulation with net release, stimulation of the coagulation pathway, stimulation of platelets, and so causing thrombo inflammation. And this is the core of microvascular thrombus formation in the COVID problem. And so patients die because of microvascular thrombo formation, because of immunothrombosis attempt, but thromboinflammation result. So how can we go from there? What do we do? How can we stop or minimize thromboinflammation? There are newer therapeutic targets that can be of help in the future. Of course, heparins are always used. And heparins not only are being used as anti-thrombotic agents, but also as anti-inflammatory agents. Recombinant antithrombin 3 might be of value, not just as antithrombotic, but also as anti-inflammatory. Recombinant activated protein C, soluble recombinant thrombomodulin, and also the recombinant tissue factor pathway inhibitor. All these will act on thromboinflammation, decreasing immunothrombosis, but in the process, not only decreasing thrombosis, but decreasing inflammation. This might be in the future of value, not only in cases of thrombosis, but also in cases of autoimmunity. So in conclusions, there is a close interrelation between immunity and thrombosis. Immunothrombosis, through aiming at pathogen removal, can cause major collateral damage. Autoimmune disorders may be associated with and affected by net inflammation. Platelets play a major role in immune cell reactions. The endothelial damage may cause further thromboinflammatory damage, and newer therapeutic options are needed. I thank you.